Well, good morning, ladies and gentlemen. I thought this was supposed to be about thyroid, but I guess parathyroid is pretty close. So we have a panel today on parathyroid guidelines, and let me just see how to work this thing. So, buongiorno, colleghi, and that's about the extent of my Italian. Good morning, colleagues, ladies and gentlemen. I'd like to introduce myself. I'm Jerry Freeman from Toronto, Canada, and I'd like to introduce our distinguished panelists and faculty. On my immediate left is Dr. Jeff Thompson from Rochester, Minnesota, Mayo Clinic, and I might say that Jeff is my go-to guy whenever I have a major problem in parathyroid issues. He's my hero. And then there's Brendan Stack next to him from Little Rock, Arkansas, University of Arkansas, home of William Jefferson Clinton, I might add. Neil Tolley, my good friend from London, England, United Kingdom. And David Scott Coombs from Cardiff, Wales, is on Neil's immediate left. And bringing up our dream team of parathyroid surgeons is Marco Raffaelli from Rome, Italy. So what I'm going to do in the next, I hope I might have an extra 10 minutes at the end. If not, I'll take it anyway, is present a number of cases on parathyroid issues that bring out nuances in parathyroid diagnostics and surgery. I'm going to assume, maybe rightly or wrongly, that everybody in the audience here knows about parathyroid stuff, how to diagnose it, parathyroid physiology, parathyroid therapeutics, and some of the issues regarding parathyroid care of patients. So without further ado, the other thing I want to do is just set guidelines. Our numbers are somewhat different from the US numbers, so I just want to make sure we're all on the same page here. Our ionized calcium normal values are 1.17 to 1.33. Our total calcium values are 2.2 to 2.6. Our PTH value range is 1.6 to 6.9, and vitamin D range is anything greater than 75 is acceptable. And there, I've added some conversion factors down at the bottom. So let's just start off with a simple case. A 40-year-old woman presents with calcium of 1.35. That's a little bit over the upper range. PTH is 6.5, which is approaching the upper range of normal, but still within normal limits. A vague history of fatigue and some focus deficiency. Her bone density is within normal limits, no history of renal stones or fractures. How do we manage this patient? Does this patient have a problem? Jeff, start with you.
So I think the key thing in this situation is that she doesn't have obvious symptomatic hyperparathyroidism, but the other important thing is her age. And I think age under 50 in somebody with primary hyperparathyroidism, which this patient has, although you haven't told us the 24-hour urine calcium.
It's slightly elevated.
Slightly elevated. So this would fit for primary hyperparathyroidism. And in a situation like this, I would offer the patient surgery because we know in somebody that's 40 years old, they have a long life expectancy, and it would be much more cost effective to deal with this patient's primary hyperparathyroidism with surgery as opposed to continued observation or cinecalcit. So once we've made that decision, then I would move on to imaging.
Okay, so I hope everybody in the audience understands this. A patient with normal PTH value does not necessarily not have hyperparathyroidism. This patient has hypercalcemia, and her PTH level should be in the lower range of normal. So this patient indeed has hyperparathyroidism. Does everybody in the panel agree with that premise? Okay, so having established that, Brendan, what do you do next?
Well, I liked what Jeffrey said was he decided that this was a surgical candidate and then ordered imaging. I think too often people go, well, let's do the imaging, it'll be a tiebreaker. And I think it's important that we don't fall into that trap. So I think imaging would be the next step. The day that we would have seen this patient, two things. Number one, we always repeat labs at our hospital because we'll be treating them at our hospital, so we want to have our baseline, and so that would help me with this Canadian lab translation thing going on for me. But I would I would have an in-office ultrasound done the day the patient was coming in, and then I'd follow that up with a 4D CT.
So your go-to imaging is ultrasound and 4D CT.
Yes.
So tell me why you don't do nuclear studies.
Well, I have done nuclear studies. I probably did them for 15 continuous years before I had this experience with 4D CT. But that one citation I just showed and some other experiences that I've had is just when I've had ambiguous nuclear medicine or non-localizing nuclear medicine results, I've always found 4D CT to be highly dependable.
Okay. Neil, what are your, I'm going to give you two studies to use. What are the two that you would use?
Ultrasound scanning and Sesame B.
Ultrasound, Sesame B. David?
The same, ultrasound and Sesame B, and if they were both negative, I would then operate. I tend to be a bit more guarded about 4D CT simply because of the, at the moment, high doses of radiation, particularly to the thyroid. So I hold that back for redos at the moment.
Marco? Two studies.
Yes, ultrasonography is quickly done during consultation, so it's not a problem. The problem is, in order to decide what next step, probably it would be better to know also urinary extraction, because if you don't know urinary calcium, probably it could be helpful to decide what
it's elevated.
doing next, because
it's
she's
elevated.
40. Okay, it's
we
elevated.
need two imaging
so
studies.
We need to operate this patient probably.
Wait a second. What two imaging studies do you use? Or do you use one?
First, US scan, and then
Sesame B
Sesame B.
and ultrasound. Jeff, what are your two go-to ones?
The same.
Sesame B ultrasound. Okay. So everybody's agreed ultrasound's easy, it's quick, it's cheap. Yes.
Quick comment about radiation dose. I think radiation is something that we should be concerned with. In our publication of our initial experience, we compared the radiation dosimetry to SPECT Sesame B CT and 4D CT. And 4D CT done with our revised protocol, which was 3 passes through the scan and a limited view, had actually lower dosimetry to the neck than a SPECT CT.
Okay, thank you. So SPECT CT is an option. Obviously, 4D CT is an option as well. Just a straw poll in the audience. What percentage of our audience participants here use as their first modality ultrasound and Sesame B? Hands up. Oh, all right. So now we have a patient that may or may not be localized. What if the calcium level was 1.17, which is a little bit elevated? Vitamin D level is 50, PTH is 7.5. Jeff, does that bother you at all?
So both of these are, the calcium and the PTH are mildly elevated, is that right?
Correct.
Okay.
Does that bother you? With a vitamin D low-ish?
Not really.
No? Okay. Yes, but I'm using our values. Okay, so it's elevated. I'm using the lower class Canadian ones here. Okay, does anybody
I'm sorry, and
on
I
the
should have
panel?
asked, I didn't know what the units were for the vitamin D. So is that elevated as well? Or it's low?
No, it's low.
Oh, it's low.
Yeah. Does that bother you?
Yeah, okay.
Would you do anything different or operate on this patient?
In the past, we would treat the vitamin D level, but we
Right.
found out now that really you don't have to do that. There was concerns about greater risk of bone hunger after surgery, but you can start replacing the vitamin D, and you don't have to get them into the normal range before
Right.
you go to surgery.
So we live in a northern cold climate where there's very little sunshine, and every patient that walks into my office has a vitamin D deficiency. So we don't pay a lot of attention to that unless the calcium is really within the normal limits. The PTH is slightly elevated. That patient needs calcium replacement. You shouldn't operate on those people. Should not. Okay, can I?
Sorry.
Yes, David.
Jerry, can I just ask the other members of the panel? Anecdotally, it's said that if the vitamin D level is lower, so the patients will have a degree of secondary hyperparathyroidism, that the normal glands might be bigger and might mislead the surgeon into removing normal glands. Do you believe in that, or do you think it's a myth?
Jeff, why don't you answer?
No, I certainly think we see that from time to time, but in most cases, it's pretty obvious what's going on.
Yeah, and just as an addendum to that, as I said, everybody in our jurisdiction has hypovitamin D-osis, and I don't see any difference in the appearance of their parathyroids when we operate on them. Just a question for the panelists now. So we're doing this operation. How many of you all do, hands up panelists, how many of you all do minimal access surgery? Okay, and Neil and David do not? You do maximal access?
It depends how you define minimal access surgery.
Okay, here's my definition.
Which I define as small incision surgery.
Through a small incision
So,
with localization.
if you're talking about a 3 centimeter incision for
No.
bilateral,
No, smaller.
no, no, then the answer is
Then you
no.
don't. Okay.
No.
David, do you?
No, I don't. I do targeted, but not through a very, very small incision.
Okay. Do you guys do four-gland explorations in the UK or no? On everybody I'm talking about.
No.
No.
No? Okay. So it's just a matter of semantics here. So how many of you in the panel use intraoperative PTH? Everybody. In the audience, when you do parathyroid surgery, hands up, how many use intraoperative PTH? How many do not? And I presume when you do not, do you do a four-gland exploration? How many do a four-gland exploration on everybody? No, but a couple of people. Okay. Okay. So let's go to the issue briefly of intraoperative PTH. Panelists, what is an acceptable drop in intraoperative PTH? Jeff?
So we use the dual criteria. People talk about the Miami criteria, which is basically a 50% drop or greater from your baseline, your pre-excision or pre-incision. And we found that we were making some errors in that situation. So with the assay...
Can I interrupt you?
Yeah.
I think you got to put an asterisk beside what Jeff just said. That is an important point. My feeling is 50% drop, not adequate.
Yeah.
I'm
So
sorry to
we
interrupt.
use the dual criteria. So not only does the PTH have to drop by at least or more than 50%, but it has to go back into the normal range for that assay. So if somebody starts out with and again, I'm going to use my numbers, 300 milligrams per deciliter PTH, and they drop down and at 5, 10, and 15 minutes they're at 140, that patient's likely not cured, and one needs to look further. So we go with the dual criteria.
That's an excellent point. Panelists, Dr. Raffaelli, what do you think is an acceptable drop?
We use the Rome criteria, as you know.
Which is? Which is? Not the Sicilian criteria?
Zero, manipulation, 10 and 20 minutes after removal of the gland. This is 50% decrease with respect to the highest one, and then still drop in between the 10 and 11 time point. This is because at the beginning we used the Miami criteria, but we observed so many false positive results, and in order to reduce the number of patients we sent home not cured, we prefer to prolong the observation time. This results in probably in highest number of unrequired bilateral exploration, but all the patients leave the operating theater usually being cured of the disease.
Okay, our UK colleagues, what do you guys accept as an adequate drop?
So I use the Miami criteria for a greater than 50% drop at 10 minutes, and our false positive rate is 1.9%.
Neil?
50%.
Brendan?
It's a 50% drop from baseline.
Okay, Brendan?
Dual criteria, but I will tell you there is a non-published Dave Terrace modification, which is we're really happy when that last number is below 40.
Is what, sorry?
Below 40, we're real happy then.
And 40 is equal to what of ours?
It's in the normal range.
In the normal range. But, okay, so what if 7 is the upper limit of normal and your drop goes to 6.5? Are you happy with that? Anybody in the panel happy with that?
I mean, there are such things as slow droppers. And I've had a few patients that were on the fence and they ultimately did great. But I don't feel good about that.
No.
And I'm not doing cartwheels out of the OR. So what are the options? Get another blood draw or go back in and take a look. I mean, that's
Yeah.
the fork in the road you're presented.
I must say that one of my failure criteria is that specific. I've been burned a couple of times on that one. So before we leave this topic, okay, here's another one. So say the incisional value of PTH goes up to 120. And remember, our upper limit of normal is roughly 6.97. So that's an enormous elevation. What then will you accept as a normal number to close up? Jeff?
Again, it would have to be back into the normal range. So for us, it would be under 65.
So, okay, so say our normal range is 7. You want it to go to 7? Say it's at 120.
Okay.
And our normal range is 7,
Mm-hmm.
which is, I don't know how many times more. You want it to go to 7.
I want it to go below 7.
So you're going to sit there for 10 hours for that to happen?
No, I'll go back and look before I do that. You know, I won't wait
Okay.
that period of time. But if it's not dropping, we see elderly patients, patients with mild renal insufficiency, there can be slow droppers. And if I start to see the things level off above the normal range, I'm uncomfortable. And so in that situation, if
Yes,
it
but
doesn't...
when do you draw the line?
So I get another one, I'll get a 20-minute sample, and if that does the same thing, I'll go back and look.
Okay. And what if you see trending down on all your samples? How many samples will you accept as a trend down? Sorry to put you on the spot.
No,
here.
that's fine. I mean, we always get a 5, 10, and a 15-minute sample. And usually in that period of time, if it truly is a single adenoma, we will see an appropriate 50% drop and back into the normal range.
Yeah. Well, I've been burned a number of times on these huge adenomas
Yep.
in elderly patients where the PTH did not drop for a day. It did drop, but it didn't drop for a day. So my friend Keith Heller, who you know
Yeah.
in New York, says, you know, I've been in this situation before, and what we got to see is trending, and you got to draw a line where that trend, that slope is interrupted.
Yeah.
Brendan, what do you think about that?
Yeah, I mean, this is a conundrum for us as well. I think 3 continuing to decrease would be reassuring, but I would not feel really good, but I'd feel a little better.
Yeah, but you know, then again, you can't sit there for a day waiting for this thing to drop. Neil, what do you do in the UK?
Well, I think the first thing is that if the pre-excision PTH goes up very high, that's sort of reassuring because you're in the right spot. And then we do one at 5 and then 10 minutes and maybe one at 15 on occasions. But it will drop quickly because the half-life is 3 or 4 minutes.
Yes.
And I think when you do the PTH assay on the ward, that's often a different assay, different units. So you're not really comparing like with like. But I think even though it's very high in pre-excision, it does come down quite quickly.
David?
In my experience.
Well, first of all, I just want to drop 50%, so 60 or lower, and I'm happy. But I think we should also just try and just to take a step back. What are we doing? We're trying to cure a patient of hyperparathyroidism in an efficient way. And if you just spend minutes and minutes and maybe an hour or 2 hours waiting for it to drop, I'm quite certain Dr. Thompson could have looked to the other side, probably taking 15 minutes, 10 minutes. So, you know, what's this about? You know, there's very little, I should think, virtually zero morbidity to Jeff looking on the other side. So I think we're almost becoming a slave to the interruptive PTH rather than just look the other side. There's no shame in a bilateral neck exploration.
Excellent point. Marco, is that what you would do?
I completely agree with David. Another issue is the type of assay we use. Because as you know, the quick PTH assay sometimes overestimates, so it's much more important the percent decline with respect to absolute level. And secondly, when we have a patient with very high pre-op level of PTH, we can have some non-functioning fragments that are detected by the 784 PTH assay we commonly use, and they are inefficient. So we have so high level that are absolutely not important for the control of the disease. While if you use another assay, you don't have that kind of fragments. So it's very important, in my opinion, knowing very well which are the systems you are using.
Thank you. So let's move on to another nuance. It's a 33-year-old male, bipolar affectational disorder, treated with lithium for 5 years. Calcium is elevated. 2.6 is the upper point of normal here for total calcium. PTH is 9.6, which is 2 points above normal. What does this patient have? Brendan?
Secondary hyperparathyroidism from lithium use, although, that's pretty quick at 5 years. In my experience, I'm seeing people that have been on it for 20 years or so, but I assume that this patient has four-gland disease.
Jeff?
It's going to need
Same?
a bilateral exploration.
Jeff?
Yeah. So, I mean, I think there's two types of effect of lithium. Lithium can induce hyperparathyroidism, but the drug itself can give you abnormal numbers in the
That's right.
absence of abnormal glands. So this is one of the few times where I would use imaging to help me.
And the imaging is?
Sestamibi.
Okay. Do the others on the panel agree with that? Does this patient have a problem? Secondary hyperparathyroidism, and if he's symptomatic in other ways other than his bipolar disorder, that he needs some sort of rectification of this.
The other thing I would say is that in the remote past, this was the only drug that was available for bipolar disorder, and you couldn't take them off it.
Right.
If they had
Now there's
now
options.
There's several other. So there's the other option of taking them off lithium and putting them on something else, and then reevaluating. But this is the one time when
is this going to reverse though?
Huh?
Will this reverse?
I don't
think so.
Yeah.
Okay, so that's a point I wanted to bring out. Always be aware of the patient with a lithium-induced secondary hyperparathyroidism. Okay, here's another little nuance. 26-year-old female, 11 weeks pregnant, has real fatigue, but what pregnant lady doesn't? Calcium is 2.8, above normal. PTH is 15, north of twice normal. No issues with the pregnancy otherwise. Ultrasound shows a 1.5 centimeter left lower parathyroid lesion. Next steps. Let's start at the other end. Marco, is this a problem or not?
Wait, I know this one.
What?
I know this one. Start here.
My go-to guy again. Marco?
11 weeks. If we see on US scan the lower parathyroid gland, we can remove it under local anesthesia without any problem.
Okay. Is there a reason to intervene during the pregnancy?
Yes, there is, because if you don't intervene, the fetus baby is exposed to the maternal hypercalcemia, and so the fetus is hypocalcemic, hypoparathyroid, and will be born with neonatal tetany, which increases fetal mortality, and there is also an increased risk, they say, of maternal mortality. So this patient does need treating in pregnancy, and I don't have my neighbour's skills, so we would do this under a GA in the second trimester.
That's an excellent point. What a clever guy you are, David, because you've just enunciated what the literature states. There's an increased incidence of fetal death. There's an increased incidence of perinatal morbidity and mortality. That is what I would classify almost as a parathyroid emergency. And we have a very high-risk obstetrical unit in our hospital, so I'm seeing more and more of these now. I've done about 8 in the last 2 years, and we bring these folks in as an emergency and do them. And it's interesting because there's a mythology in the air now about operating on patients, pregnant patients, in the second trimester. And my colleagues in the obstetrical circles say that is mythology. You can operate on these patients in the third trimester, and it probably doesn't make a difference. But nonetheless, this is a real emergency that has to be dealt with in order to avoid perinatal and maternal mortality and morbidity. Panelists, do you all agree with that? Jeff?
In addition to the concerns about neonatal tetany, there's significant concerns about bone mineralization in the fetus. And so the sooner you get to it, the better the chance that the baby will be born with normal bone structure.
Excellent point. So I was at a meeting once, and a very prominent parathyroid surgeon got up and said there's no such thing as hyperparathyroid emergencies. Do you agree with that, panelists?
No.
Okay. Can you give me a laundry list of hyperparathyroid emergencies? Jeff, starting with 1.
Hypercalcemic crisis.
Okay. Brendan?
Calciphylaxis.
Okay. Neil?
Emergency admission, severe dehydration
Okay.
management.
David?
Well, pregnancy.
Yes. Marco?
Severe mental status, yeah.
Okay. So I think this kind of summarizes it. How about pancreatitis? Is that one? I've had at least 3 or 4 patients now in the last year or so with severe pancreatitis. We took out their parathyroids and that was cured. Intractable symptoms, patients with major pain in joints and bones. I'm not saying that's an emergency, but I'm saying that patient needs to be done. What about patients with chronic renal failure? Tell me a little bit about that. Jeff, do you get these folks?
Well, it depends on the degree of how high their parathyroid hormone level is.
We're talking about in the hundreds in our jurisdiction.
Yeah, in the hundreds, I don't think it's an emergency.
No, hundreds when the upper limit of normal is 1 point.
Oh, here we go again.
1.7.
Okay, well take that back. Yes.
Okay. So in our province, patients are not allowed to go on the transplant list until their hyperparathyroidism is dealt with. Right. I'm not sure about other jurisdictions. Jeff, what about Mayo? Same?
Same.
Yeah. UK guys? Same. Marco? Same in Rome? Yeah. And pregnancy, of course. So do symptoms matter? Tell me a bit about symptoms. Do you guys believe that every patient with hyperparathyroidism has symptoms if you ask them?
No.
Deeply enough. Neil?
No, I think it's very variable. It always amazes me that you can have patients with a calcium over 3 and they're asymptomatic. And then patients with a relatively mild rise in calcium can have severe symptoms. So I think the correlation of symptoms with the calcium is generally quite poor. And the 74 symptoms that have been associated with primary hyperparathyroidism, and many of them you'd see in the general population as well. So I don't think symptoms always is a good indicator.
Yeah, I've just run through a bunch of slides that tells us that patients with bone mineral density issues are reversed, incidence of renal stones goes down, life expectancy goes up, coronary artery disease goes down, patients who didn't think they were fatigued are miraculously feeling better. Do you guys believe in all that neurocognitive stuff getting better?
Yeah.
Yeah, certainly. I can say 80 to 90% of my patients don't know how crappy they felt until you do their operation.
Agreed.
David?
Well, I agree with all that, but there is an emerging patient population who are absolutely full of symptoms, have a normal calcium, and goodness knows why, but someone's measured their PTH, and it's slightly high. And they are a very difficult, disaffected group of patients to manage.
and you don't operate on those patients.
No.
Somebody once told me when I was starting in practice, it was a very wise thing he said to me. He said, you know what? Never operate on crazy patients. And that has stood me in good stead. Okay, let's do this one. 65-year-old woman with history of sarcoidosis with mediastinal nodes, severe bone pain, some response to systemic steroid, found to have calcium 2.9, that's pretty well elevated. PTH is 15, north of twice normal. Imaging all negative. What do you do next?
Measure the ionized calcium.
Measure the ionized calcium. Measure of the ionized calcium is significantly elevated. So this is a patient I discussed, I remember, a couple of years ago with Jeff. So I'm not going to ask you. But Brendan, what would you do here?
Well,
And excuse me for interrupting. Remember, the key point here is that hypercalcemia can exist with sarcoid and hyperparathyroidism. So how do you knead out these two things, Brendan?
yeah, I think that's a very good point. They can be one or the other, or they can be overlapping. Lightning can strike twice. Do we have a tissue diagnosis of the sarcoid?
Yes.
Then I would probably go ahead and proceed as a primary hyperparathyroid patient presenting to me and acknowledge that sarcoidosis might be playing a role, but then proceed forward as a normal surgical patient.
Okay, but how would you stabilize this patient so you know that postoperatively you've been successful?
Well, in terms of the PTH, I'm not aware that the sarcoidosis would affect my intraoperative PTH measurement, and otherwise I would just manage the hypercalcemia medically.
Jeff, what do you think?
Same. I mean,
Is there
if
something
this
else
would
we can do diagnostically here?
Meaning in terms of differentiating sarcoidosis from
The hypercalcemia of sarcoid and hyperparathyroidism.
Well, I think the
dose of
PTH,
steroids.
I think the PTH of 15.6 goes against the sarcoidosis being the cause of the hypercalcemia.
And it didn't suppress on the steroids?
It did a little bit.
Yes, but not sufficiently. And the calcium's very high.
Yeah. So, David, any bright ideas?
No, but I wouldn't necessarily be using intraoperative PTH here because the imaging's negative. In everyone's experience, negative imaging means a likelihood of multiple gland disease of around 20%. So these patients should have a bilateral neck exploration anyway.
Okay, Marco, do you agree with that?
Completely agree, yeah.
Yeah. So the only one thing I might add, and Jeff, you told me to do this, was do their angiotensin converting enzyme levels, which we did, which were severely elevated. We put her on maximal doses of steroid, brought her calcium down a little bit, probably to their baseline, notwithstanding the hyperparathyroidism. We did her surgery. She had 4-gland disease, and she was normal after the operation. So that's, I think, a salient point in dealing with patients with sarcoid and hyperparathyroidism. I'm just going to, in the interests of time, I'm just going to go through okay. I've got all sorts of stuff here. Okay, here's something. So a 33-year-old woman comes to see me, and she had a recent removal of a parathyroid adenoma at the Elsewhere General Hospital. She still feels fatigue, bone pain, mood disorder, and sleep issues. Recent biochemistry, calcium 3.0, which is very, very high. PTH is 45, which is, again, our upper limit of normal is 7 or so, so it's 4 times or so normal. And her vitamin D is normal. Her MIB shows intense uptake in the right lower field. What do you think, guys?
Where was the other one taken from? The original one?
The original one was the right upper parathyroid.
Well, we need some MEN studies, don't we?
Sorry?
We need some genetic studies on this
Genetic
patient.
studies?
Yeah, we
Okay,
need
what
MEN.
what do you suggest?
She needs an MEN screen.
Her MEN is negative.
What I'm thinking of when I hear this is that there's a low-lying superior. They went in maybe to the right quadrant, the proper quadrant, took out a normal gland and didn't go deep enough and missed the offending gland.
Okay, so I got the old OR note, which I never do, by the way, or hardly ever do, because if you read old OR notes, every surgery that's ever done by a surgeon is done in the most exemplary way possible. So OR notes are not much use to me. But this OR note actually claimed minor spillage, and the pathology showed a ruptured adenoma measuring 2.5 centimeters. So CT was done, showed an amorphous mass in the right lower field. What do you think is going on here now? David?
Well, we're once worrying that the patient has parathyroidism, which is a sort of disseminated growth of parathyroid tissue, which is akin to sort of malignancy, which is a very difficult problem to manage. So it's best. Oh.
Go ahead. Don't be surprised.
I do some parathyroid jaw syndrome. That's what you're going to say, wasn't it?
Okay, so right. So
Don't let me interrupt you. Sorry.
all right. Well, I think the patient needs a re-exploration, and you're trying to carve out the disease with, as best you can, a clear resection margin, but you would warn them that it could be difficult, that there's greater risks of injury to particularly the recurrent laryngeal nerve and higher risks of failure.
Okay, let me ask the panelists. All of you are expert parathyroid surgeons. In your whole career, hands up if you've ever spilled a parathyroid tumor.